So I want to welcome everybody to our first grand rounds of the academic calendar. And we're very fortunate to have Dr. Goldberg, Dr. Packo, and Dr. Lim here, who are all residents with Dr. Goldberg and alumni of the residency program. And I'd love to just bring this back. So in the history of the department, and I've heard so many things about the grand rounds that Dr. Goldberg would run, and it was called the Super Bowl. And I think Dr. Packo is going to give us a little bit more introduction around that. But just to give everyone a history, I think most of the folks here are alumni, and really this is more for the residents and the new folks. Really say was founded by Dr. Goldberg, right? And this is the 50th anniversary of when you came from Baltimore to run the new department at UIC. You know, and you did so for 19 years. And it was really, just life-changing for many people, and for many people on this call and on this meeting right now, with all the luminaries in the field. And Marilyn's on the call. She just called me, and Golan Payman, and many folks that we can mention on and on and on. And the traditions that you developed. And I love this picture. This is apparently, so someone showed this to me and said, Paul, you have to do some sort of dance. And as most people know, I don't really dance, but I would love to see this dance more at some point. Apparently this was legendary. But we're so grateful to have you and Kirk and Jenny here for our first grand rounds to kick off our academic year. So I'll hand it over to you, Mort.
Well, Paul, I can't thank you enough. Returning to the Wednesday afternoon clinical case conference is a dream come true. I look forward to this session so much, and I want to thank you for your wonderful leadership of the department. And behind you is a planned enlargement of the Lions building, which I think is marvelous. And I know you'll be successful at it. And I just want to mention how much I love this particular conference. I learned so much from it. I continue to go to these types of conferences virtually, I must say virtuously, because I love them and I want to keep learning. And if I can keep teaching a little bit, why, so much the better. And what a pleasure, and what a delight to return with Kirk Packo and Jenny Lim, two of the most distinguished alumni in the history of the department. Jenny has become such a leader in retinal disease and surgery. She's really the world's leader in research on sickle cell retinopathy and other aspects of clinical retinal disease. Kirk Packo has just finished 16 extraordinary years as chairman of ophthalmology at Rush. And what Jenny and Kirk have in common is not only extraordinary clinical skills, both in outpatient ophthalmology and in the operating room, but extraordinary compassion for their patients. They never give up. They always search for success for the patients one way or another, with extraordinary ethics in all things related to life in general and ophthalmology in particular. So I love these two people. I love the alumni of the infirmary. So many are on the conference call today. It's wonderfully gratifying. Thank you so much, everybody who's listening in, viewing online. It's a great pleasure to return. What a treat. This reminds me that my 19 years at Illinois were without doubt, the most important years of my entire professional life. I reflect on them with the greatest of pleasure and the most wonderful gratification. So thanks to everybody who made that time so special. So let's turn the session over to Kirk Packo, one of the greatest teachers of vitreoretinal surgery that the world has ever seen. Kirk, it's all yours. Oh, and by the way, folks, I've already received permission from Kirk to interrupt him. After all, he's no longer chairman, he can be interrupted now.
That's right.
And I'm going to invite everybody listening in to interrupt whenever they want to, if Paul can unmute people without destroying the clarity of the audio. So that, like the good old days, you can be interrupted with a question or a comment whenever you feel like it. And I hope you will. So Kirk, go ahead.
Thanks, Mort. We were chatting right at the start of this, and it's such a treat to come back. It's really like doing your favorite thing you dream about. At least I do as an adult. You want to be able to go back in a time machine to happy days and things that are so fun, whether it's going back to your college days or as a kid visiting grandparents when you were 10 years old and so on. Well, one of the places that I would love to revisit again were the wonderful years I had at the infirmary. And I think of such fondness of being a resident there in an extraordinary time when it was just this amazing thirst to learn. And Mort really created that culture in all of us, in the faculty and the residents, where everybody was there to learn and we were excited about learning. And you all know the rich history of the infirmary. There's 6 training programs in Chicago, and yet the glue that ties us all together and the reason why we get along so well together, whether it's Loyola, Northwestern, Rush, is because of the infirmary. And the Ioneer Infirmary just is that amazing presence in the different eras that went through. I think probably one of the greatest eras is the era of Morton Goldberg, and I was just so honored to be part of that. This in my office, I just grabbed this. This is a brochure I bought on eBay from the Charitable Ioneer Infirmary from the turn of the century, and there's some great photographs in there just to show you how the Super Bowls have changed. So this was the infirmary. This was a picture of surgery being done at the Ioneer Infirmary in the brochure. And with a theater behind it is amazing. And then, you know, the teaching was you had a patient and people would learn from the mentor, the lead physician, and the students would gather around the patient to learn. And the Super Bowl was the same thing. Every week we had these cases that would just walk in off the street with amazing pathology, and we would gather the patients together and we would bring them into exam room. We would examine them all, and then we would go to the auditorium where the magic took place. And Mort ran it and just masterfully gathered comments from everybody, and everybody left that day learning a little bit more. So I got a great case, a typical infirmary case that just walks in off the street to show and to kick it off in a nostalgic view. So with that, let me share my screen here. Okay. Place here. You know what? Let me.
We can see it now, Kirk.
Here we go.
We just lost it. We can see your cursor.
You can see my cursor, right? Okay.
Yeah.
Okay.
There we go. Yeah.
Okay, so it was the Super Bowl, right? Well, we're going to relive the Super Bowl again, 1855 Taylor Street Super Bowl. And of course, the Super Bowl Moderator Hall of Fame, Morton Goldberg, is going to take us through these 2 cases, mine and Jenny's today. So, Mort, let's give you the history here.
Wait a moment, Kirk, hold on. Look up, folks, there's a nice picture of a pan-retinal photocoagulation. And the inscription in the end zone says Ioneer Infirmary.
Yeah,
only Kirk Packo could have done
inked
that.
it out in the end zone, right? Ioneer Infirmary. Okay, so I got a case of focal choroidal excavations. That's the teaser here as we get going to it. So what do we have? We have a 29-year-old myopic male, fellow I saw just early last year, referred by an optometrist for focal choroidal excavations.
Well,
Now, he had
hold on,
prior eye
hold on,
exams, he was
Kirk.
never told he ever had
Kirk.
any problem, and he had no visual complaints. He was sent in by optometrist. He was annoyed that he was there. He didn't want any imaging done. He said, "Why are you sending me for this?" I just wanted to. He was late for work, and he just wanted out of there. He was 20/20, and his anterior segment was normal. But
Can I interrupt you, Kirk?
it was a Super Bowl case. So let's kick off and show you the fundus. So here's what the optometrist saw. The nerves were fovea were normal. There was a nevus below the fovea, nothing exotic there. But he had this lesion in the just above the fovea. It's kind of a football shape, if you will. There's some pigmentation on either edges along the margins, but the ends were kind of hypopigmented, if anything. But a little did so there, and it was, you can see it above the supratemporal arcade there. Otherwise 20/20. Now there's other pigmentary changes in the periphery. And again, we see these little pigmented ditzels that we notice, but if you look at them, there's some patterns to it. So you got this thing supranasally, kind of oval shaped again with a hypopigmented cap pointing back towards the macula. Another tiny one at 12 o'clock there with, again, a hypopigmented area pointing back to the posterior pole. And then these non-specific hypopigmented and pigmented things in the periphery, a little pigmented glob. I suppose you could mistake that for lattice degeneration. But, you know, some things there. So here's the OCT of the macula. Central macula looks normal, 20/20. And here's that lesion up above the supratemporal arcade. It has a little missing area here, a cavitated area. I'll use that term for you. The choroid beneath it in this cut was pretty normal. If you do an en face looking down at it, the nerve fiber layer is normal. The OCTA, the internal layer of the retinal capillaries, was normal. And you start to lose some deep capillaries, and there's some loss of choriocapillaris within that lesion. So there is some vascular loss there. The OCTA didn't show any abnormal vascularization coming from behind, so no choroidal vascularization. The left fundus had a lot more striking findings, but again, it's more of the same. So there's a big lesion in the macula. Again, a hyperpigmented edge along inferiorly, and then the pigment is abnormal but fans out superiorly. So again, there's more pigment here than there should be on either side of this lesion. And there's a second lesion right next to it with the same thing. And again, there's a little hypopigmented thing pointing posteriorly. Another one, temporal macula, same kind of thing. Oval, hypopigmented, pointing south, pigmented edges. Here's one nasally, pigmented all around. Not much pigment in the center, but some mottling. Again, a little hypopigmented cap pointing towards the optic nerve. Another one inferior to the optic nerve. So a lot of them. Another one inferior periphery. So this one had a lot. If you do a composite, you see a bunch of them here. OCT of the macula, 20/20, normal. Maybe a little pigmentary change, drusen-like change. But now this is the main lesion in the macula. So now again, you see this lucent area here, a little bit of fluid, I guess. But the choroid is distinctly thinner here now, and there's some transmission through it as a close-up of the same. And maybe the pigment epithelial layers are a little abnormal through it, but the choroid is certainly rarefied there. Now, when you do the OCTA coming through it, inner capillaries normal, deeper capillaries you start to lose it, and the choriocapillaris is lost. So you have some choroidal loss of vascularization here. OCTA, nothing abnormal. So I collected them all. Here's the right eye. There's that one lesion that the optometrist saw, but here's the whole collection of the gamut of the things that are in that right eye. And again, little tiny things, but they're kind of reminiscent of each of that main one with that hypopigmented thing pointing posteriorly. And the left eye has these bigger lesions, and they all look fairly similar. I think they look like apple seeds with the little barb to the end of it. Okay, so there you can add these to the apple seeds there. So there's the case, Mort. So the question is, what's the diagnosis? Does anybody want any information? Anybody want to ask any questions? What's going on here? This kid wants to go home.
Yeah, I want to ask you a question. Kirk, can you hear me?
Gastrointestinal status.
Kirk, can you hear me? Hello?
So we can hear you, Mort. So
Okay.
yeah,
Well, I've got a question for Kirk. You're pulling something fishy on us.
Wait a minute, hold on.
I am thoroughly impressed by this optometrist who made a referral diagnosis of one of the rarest entities in all of clinical retinal disease. The optometrist said he had focal choroidal excavations.
Yeah.
Well, I feel a little bit unwanted here because I've never seen a case of focal choroidal excavations. I'm not sure this particular patient has focal choroidal excavations, at least not classical ones that I've seen in the literature. I just wonder if anybody in the audience has ever seen a case of focal choroidal excavation, much less heard of it. Dr. Chan, you're a retinal expert. Have you ever made a diagnosis of focal choroidal excavation?
No, but I think Kirk just gave us the answer for this case.
Yeah, he does. How about Dr. Mueller? He's a retinal expert. Have you ever diagnosed focal choroidal excavation?
Yeah, but not in this kind of a setting. Certainly we've seen that, but this is different.
This is somewhat different because it's pigmented, but maybe
Yeah,
there's more to the story.
I'd ask Kirk for a history of gastrointestinal status.
Okay.
Well, you see there, it's had pancreatitis. And he's a young guy, what I say, 29 years old with pancreatitis. I asked him if he drank. He said no.
I guess we could, Kirk, would you be open to asking some of the residents if they had any thoughts on this?
Sure.
Let's see
So
who's
what
on.
else would you want to know?
Yeah, so Aaron Kaufman's on. Aaron, do you want to ask any questions for Dr. Packo?
Sure. So unfortunately, I missed the beginning of the presentation. We just finished in clinic a few moments ago. So I apologize. I missed most of the clinical stem.
Well, he had a lot of pigmented lesions that had a very variable pigmentation, some oval lesions that had a lot of loss of pigment or less pigment with pigmented edges and little hypopigmented barbs at the end. They were pointing posteriorly. And then the term excavation that the optometrist threw on the table here is it looked like it was sunken in, and the OCT does show that it dips down and there's some little loss of choriocapillaris, so it does go in deeper. I think the word excavation to me indicates something which is not stagnant in time, but something which is progressing and something's dishing it out or making it worse. I don't know what this kid looked like when he was 5 years old, but I suspect that these lesions look the same years ago as they look today. I don't think there's anything progressive about the retinal lesions.
Any examination of family members or any family history of similar lesions?
I asked about people in the family. He didn't really want to go into his family history, but he said, no, everybody's fine.
Morty and Mort, do you want to ask any of your previous residents on the call?
Well, Jenny Lim's another retinal expert right there. Have you ever made a diagnosis of focal choroidal excavations, Jenny?
You're on mute, Jenny.
Ooh, funky.
You're still on mute, Jenny.
How about Mike Ellman from Baltimore? An infirmary alumnus, a great retinal specialist with a very, very booming practice here in Baltimore. Mike, have you've seen hundreds of thousands of patients. Have you ever made a diagnosis of focal choroidal excavation?
Not in the flesh. How were the pupils?
Pupils were normal. My tech looked at them. I didn't see them, but they were listed as normal.
Never seen it in the flesh.
No. I suspect they were normal. Vision was 20/20 OU, so there wasn't an afferent defect to worry about.
Okay, Kirk.
Well, he did have some endoscopy. It was followed by a GI specialist. And he said that he had some stomach polyps that were taken out that were benign. And I asked him, well, you're kind of young for polyps, aren't you? And he says, yeah. And he said, but they were benign. And the doctor said that he just periodically need to look at them. And his polyps were probably responsible for his pancreatitis because they were upper GI polyps. And
Kirk,
if you ask him more, he had some extra teeth. He had a couple extra teeth in his upper bridge behind the first row of teeth. I didn't get a picture. I wish I did. So anything else on the list there? So now we're starting to get some things that did. And actually, when you tested and got some more family history out of it, his mother was deceased. And I found this out later on a phone call afterwards, and because he didn't tell me what then, but she died of stomach cancer. So you got GI cancers here. And
Hey,
the
Kirk.
kid with polyps at age 29. So now what's the diagnosis?
So Bill had a comment. Dr. Mueller? Nope.
Bill, if you're trying to talk, you're on mute.
You hear me now?
Yeah, we can hear you.
You know, Kirk, when I see multiple pigmented spots with little white edges pointing posteriorly, I get concerned about Gardner syndrome and colon cancer. That's why I asked the question about GI issues.
Gardner syndrome. Okay. What's Gardner syndrome? All right. Anybody else want to weigh in here? All right. So we got another case to get to. So let's go through this. So Bill has it. So he has multifocal congenital hypertrophy of the RPE with familial adenomatous polyposis, or the Gardner syndrome, as Bill mentioned. Now, this name, congenital hypertrophy, back again when I was a resident in 1855, Taylor, we had the thought that Gardner syndrome was, I mean, my memory of it was chirpy with GI tumors. And congenital hypertrophy, as it's in the literature on some of this, in the early literature, and a lot of the literature on Gardner syndrome, I think is incorrect, according to some later authors, that the histology, this really isn't hypertrophy, and it's not chirpy, but it's really more of a hamartoma. There's hamartomatous cells here, which we'll get into. So a little bit in the history, Eldon Gardner from Utah, University of Utah, was described as systemic syndrome. It's autosomal dominant. Mom died of cancer. And it's characterized by multiple colonic polyps and tumors all throughout the GI tract. It's pretty rare. It's been genetically typed. There's a tumor suppressor gene called the APC gene, the adenomatous polyposis coli gene. It's on the chromosome 5, and there's multiple mutations that can do that. So the syndrome is, as we're talking about, colon polyps that have 100% malignancy rate, 100%. Gastric polyps that just layer through the entire stomach. And here's what this kid probably looked like. This was from the literature, but this is a duodenal polyps that are obstructing the ampulla of Vater. That's why they get bouts of pancreatitis, because the polyps just obstruct and they get a backward pressure into the pancreas. They get benign lesions, osteomas in the mandible, epidermoid cysts around the ears, supernumerary teeth, other dental abnormalities, and other types of cancers too, in some pedigrees, particularly thyroid cancer. And you get these pigmented lesions in the retina, which are really a good biomarker. And I'll show you the incidence of these within Gardner syndrome. But it's almost universal, but in some things up to 90% or more. Again, the benign lesions in the skull, I didn't see any on this young man. I looked at his ears, but he may have had something subtle. He did have a couple extra teeth that he told me about on a phone call later. After I'd read a little bit about it. And this is obviously a horrendous case of supernumerary teeth in Gardner syndrome. The polyps are everywhere, and they're by the thousands. And so they can just blanket the entire colon here. And you get gastric polyps too, which are unusual, duodenal adenomas, and malignant transformation, 100% by age 40. And this young man's on his way there. And you treat it with a total colectomy, which is just life-altering, like you can imagine, because they anastomose the small intestines to the anus. So there's no chance for water reabsorption. So it's a lifelong diarrhea of 5 to 10 bowel movements a day. And you need lifelong surveillance because they'll get recurrent tumors within the anus with some little colonic tissue that may be left there. So you have the Gardner syndrome, there's a couple of variants. There's a thing called two-cut syndrome, which I learned is with brain tumors as well. Cowden syndrome is the one that has the thyroid cancer with it and breast cancer. And then there's an attenuated form which has less polyps but still has the malignant transformation. And these things, these are 4 different patients, not my patients, that have this apple seed appearance with the oval, and as Bill pointed out, that little barb that points more posteriorly, again, different from chirpy. Trabulsi and Gardner and our friend Irene Momini was on a paper back in the late 80s looking at how common the pigmented lesions are. And Dr. Gardner was part of that paper. They looked at 16 different pedigrees, and they found, as you can see here, the patients with Gardner syndrome had it bilaterally or unilaterally, were over 90% of the time you see the retinal lesions. And it went down based on which pedigree you looked at, because you can see these pigmented lesions in other family members based on the whether or not first or second degrees you're looking at compared to control members. So the retinal lesions are a good marker and a pretty strong indicator. So this is the paper that suggested these are hamartomas. There is some histology on these, and there's multiple layers and mounds of RPE cells. So they're interspersed outside of and around Brooks membrane too. So it's not just increased size of cells. So they suggest that this is really a hamartoma of the RPE. And there's also a defect in melanogenesis, which you can trace to that APC mutation too. Chirpy looks different. It may have some similarities. It's round rather than oval. That's not that oval lesions. There can be some hypopigmented edges, but it's not that barb. You can have lacunae, and this lesion looks maybe a little similar to what I've been showing, but so there is, I guess, within the differential something there. Bear tracks is a lot of these, but again, it's not the kind of things that I showed you within that left eye, this young man. The thing that does look a lot like this, and Morton and I talked about this a little bit, is torpedo maculopathy, because again, you have this oval lesion with the barb at the end of it. And again, Don Gass described this, one of his many diseases, did it first, temporal macula solitary lesion. With the same types of changes on morphology and imaging. He described a type 2 lesion here, 1 and 2, and that has this cavitation, which he described, but nobody has described any systemic diseases with torpedo. Here's Grimaldi has a paper, when was this, in 2018, of a little girl with torpedo. Again, a single solitary lesion, a little similar to that lesion I showed you in the macula of this young man. But the interesting thing is that the OCT look real similar to the OCT of Gardner syndrome. Here, the choroid is of a normal thickness. So it's
Kirk, let me interrupt you. What
Yeah.
does that tell you about the primary tissue of involvement in these lesions? Is it the pigment epithelium or the choroid?
That's a great question. I have to think it's the pigment epithelium.
Absolutely right. And you'd have to conclude that the expression of the mutated gene, the APC gene, is having an effect on the retinal pigment epithelium.
Right. And I'll show you here in a second, there's a mouse model that proves exactly that. And again, this is this type 2 torpedo maculopathy. But again, there's my patient, looks pretty similar. Here, the only difference is the choroid's a lot thinner here compared to the torpedo case, which is why they called it the cavitation.
So there, the optometrist was right, wasn't he? Focal choroidal excavation. Look at this OCT.
Yeah.
How did he know that? What kind of a brilliant person was that?
You hand wrote it on his referral note.
Well, send him some candy kisses.
OCTA in this torpedo case, again, real similar to what I showed, deep capillary loss and chorocapillaris loss, no abnormal vasculature otherwise within it, and some loss of outer retina and thinning of the choriocapillaris, some more segmentation of the retinal layers overlying that cavitated area.
Can I make a quick comment about that APC gene in this particular OCT, and also the one where the pigment epithelium was outpouched into the choroidal cavitation? You know, it's a tumor suppressor gene, as you said, Kirk, and its functions as a tumor suppressor. When mutated, cells lose their adhesive properties and they detach from other cells, and they also proliferate, as you mentioned in that Trabulsi paper, with mounds of RPE under the RPE, separating the RPE from Bruch's membrane. Well, here you see separated RPE cells from Bruch's membrane. And I suspect that the APC mutation not only is affecting the polyps in the gastrointestinal tract, but also the retinal pigment epithelium, losing its adhesive properties and migrating and proliferating.
You wonder, there's melanin elsewhere in the body. You wonder why they don't have skin lesions or chorda tympani defects and things too. What was it about the focal lesions in the eye that predisposes it, and melanin elsewhere doesn't seem to have the effect? I don't know. This paper again looked at multimodal imaging of a torpedo, and again, remarkably similar look on that OCT, with the exception that the choroid's thicker. This was the paper from Lee and Mark Daly, and I talked with these two guys about this, and their thought on this paper back 10 years ago was that they thought it was a malformation of the emissary canal of the posterior ciliary artery and nerve. It's a good bet it kind of comes in that area too. And with these emissary canals do have pigment around them. Maybe there's something that relates to this. But what I think is intriguing is that no one's ever genetically looked at torpedo. Now the APC, as Mort mentioned, is a tumor suppressor function, and there's different mutations on that in that locus that can give a variety of mutations that we all lump together as an APC. And there's a difference in some are worse than others here. And again, it causes the changes in the retina. It's a good biomarker. This is the mouse model.
Well, that's correct. Go back just for a second. Go back for a second. That's really an important slide. You mentioned the attenuated familial adenomatous polyposis syndrome, and that has a mutation in one part of the APC gene. Turns out there are over 800 mutations in the APC gene. And for example, the supernumerary teeth occur from a mutation in a different part of the gene from that of the attenuated polyposis syndrome. So it's entirely possible that one part of this gene, if mutated in a particular area, causes that torpedo-like lesion. I think the torpedo lesion needs to be re-examined in non-Gardner cases to see if there's some sort of a mutation in the APC gene responsible for torpedoes, even in the absence of the Gardner syndrome.
Yeah, I agree. The mouse model, where you can create an APC defect in a mouse model, shows an abnormal hyperplastic reaction to the pigment epithelium, abnormal melanosomes, and increased in number compared to the normal mouse to the side. And this was a mutation that was genetically engineered at 1638 there.
And these macromelanosomes are the same things that occur in X-linked ocular albinism.
Yeah, right. Mm-hmm. And then the same authors looked at this in mice as well, the histology of the retina showing depigmented RPE at one edge and hyperpigmented areas, and even what we call the little coloboma or cleft lesion here, where it's broken in between. So again, there's some histologic similarities to the human too. So as Mort mentioned, torpedo and Gardner really share a lot of phenotypical similarities, and we've been led down the garden path on phenotypes that have nothing to do with each other genetically. But I think there's enough intriguing here to say, and no one's looked. You know, it's I remember asking Gary Brown once about Wyburn Mason, and in his book he said grade 1 Wyburn Mason never have CNS abnormalities. And I said, I have a grade 1 Wyburn Mason that has a big AV malformation in the brain. And he says, well, maybe I should say we never looked. And that's why he wrote that they don't get it. So again, you got to look and say, you can only say it that it's not associated with problems unless you look. And there may be some things even systemically going on with torpedo that may be at a subtle level that may have some GI issues here. But I think it's worthy of looking at these. And part of this is throwing out, if anybody's got any torpedoes, I don't have a torpedo case. I can't get my partners to get them to bring these patients back, but no one's looked for it. Anyway, just to finish off here, the treatment for Gardner syndrome is total colectomy. Then there's some other things medically you can do in chemotherapies to try and reduce the incidence of the cancers, calcium, and they need a psychiatrist because life has just changed in such a horrendous way. You can imagine where the bathroom now rules your life. And the final follow-up here, the gastroenterologist I called, and I asked him, I said, gee, I think this kid has Gardner syndrome. And there was this pause, and he says, oh, yeah, okay. So here's a guy, gastroenterologist, found a young man for polyps and didn't entertain the diagnosis of Gardner syndrome. And interestingly, the endocrinologist wrote a paper on Gardner syndrome years ago and the psychiatric problems that they get. So what happened to this young man? He did get typed. He did have the APC mutation, and about 4 months ago had a total colectomy. So and I haven't talked with him since then. And you know, basically his life is altered, but he just at least has his life now. The reason, again, I'm so love this case for this forum is that this is the kind of stuff that we saw at the infirmary every week. They would just walk in, and we'd see cases like this, and the chief resident would grab you by the collar and say, you got to show this one to Mort. Let's bring him back next week and bring the patient in. And I remember what the waiting room at the infirmary looked like. And waiting out there, just walking in off the street, was the most incredible pathology. Any one of these cases could be a great Super Bowl case, right? So let's finish off our Super Bowl here. I think the winners is definitely the Eye and Ear Infirmary. We beat out the baby docs at the Wilmer Eye Institute at the score of 34-28. And I want to thank Mort for giving me the joy of joys in the Super Bowl at the Eye and Ear Infirmary. And there's Mort during my senior year with a less hirsute, much thinner young man, Kirk Packo. So thanks, Mort.
Well, thank you, Kirk. What a brilliant diagnosis. You not only made a fabulous diagnosis and presented it beautifully, as you always do, but you saved this man's life. And for that family will always be grateful. Of course, you exchanged a lifetime of diarrhea, but I'm sure they put things in perspective.
Yeah.
Congratulations, Kirk. It was a wonderful, extraordinarily educational case. And I hope that the issue of torpedo maculopathy is revisited and that those cases have genomic screening to see if indeed they're carrying an APC mutation, even one of them eccentrically located mutations in the APC gene in chromosome number 5. So you've given us a lot of stimulation, and do congratulate the optometrist. What an incredible referral. Thank you, Kirk.
Thanks, Martin.
Well, Jenny Lim, are you ready to roll?
I am ready, and I figured out how to unmute the microphone. Sorry about that. Let me pull up my screen and share it. Can you see it?
Yep.
Okay, so really, Dr. Goldberg, it is wonderful to have you with us today, and just like everybody else reminiscing about the old rounds. The residents, I always say, you know, when I was a resident, we would have to examine the patient, and then you never knew when Dr. Goldberg was going to call you out in the audience to ask you, what did you see? And it really kept us on our toes. It made us astute observers. It made us really great clinicians, and we always had to think. And so thank you, Dr. Goldberg, for making us into the best ophthalmologists that we could be. So I don't want to get choked up here, so I'm going to move on. And my, Kirk, that was a wonderful case. My case will be more pedantic and not as esoteric. I say that, and let's see what the residents can do. So this is a curious case of peripheral vascular change. For the residents out there, I will call on the second and third years. Patient CM presented to me, 33-year-old man, complaining of floaters for the past 2 years. And on review of systems, he said, yep, I lost a hearing in my right ear. Other than that, he said he's perfectly okay. His vision was 20/25, and the slit lamp exam was essentially normal. So here's what his right eye looked like. I know there are some second years on the call. Paul, you may have to help me out. I can't see the list of all the residents. Aaron, we've already called on you. So let me see. Is Sean Gulati here?
So Sean, are you on? I don't see you. I see Catherine's here.
Catherine, what do you see in this right eye? And Dr. Goldberg, you can take over this role part if you'd like to call on the residents like you used to do.
Catherine Jaltikov.
Yes, can you hear me?
Yes.
Okay, I'm on my phone, so it's a little bit small, but this is a fundus photo of the right eye, and the media is clear. The disc margins look sharp. The disc, I can't see the cup. It does look a little bit pale, but it might just be the
Poor exposure.
effect from the
Cup's normal.
photo. Yeah, normal. Vessels look, I would say, pretty normal and coarse in caliber. There are a couple of white, actually, I think that's
Tell me where. Tell
so
me where
in
you
the,
see 'em.
yeah, so nasal to the nerve in the far periphery, there is a like a fawn, neovascular fawn. Yeah, that area right
Good.
there.
Anything else when you look closely here? What do you see? Or actually, Dr. Goldberg, do you want to take over this part? Catherine, what do you see? I'll have Dr. Goldberg ask you.
I see lots of very thin blood vessels with AV anastomoses and a lot of tortuosity.
Good.
And
Okay.
a couple of more areas of AV anastomoses nasal to the nerve there, right there where you're pointing.
Excellent. Anything else?
And then temporal to the macula, yeah, right there. There's a couple more areas of C-fans and AV anastomoses with some whitening around them.
Maybe out here. Okay, and then let me, and
What
anything
do you
else?
think about these, Catherine? Are these artifacts or are these real cloudy opacifications in the macular region?
I think that they're probably real. It could be maybe like a cotton wool spot, some ischemia.
Clinically, it was not a cotton wool spot. You're referring to these areas?
Oh, those ones.
And then
okay.
that one. Okay, but there was some change in color. Let me show you his left eye. Okay, you're doing well, Catherine. You want to keep going? You're going to pass
yeah,
on.
sure.
Okay.
So this is the fundus photo of the left eye. Again, media looks clear. Again, in the periphery, we see, I think these are like sunburst lesions with, yeah, those ones that you're pointing to. It looks like sickle cell retinopathy to me.
Okay.
How
And
about
is-
this one right here?
where are you pointing, Dr. Goldberg?
Where are you pointing?
Oh, sorry,
Sorry, we
I have a
can't see it.
pointer, but you can't see it, I guess. It's
You pointing to these here?
just supratemporal to that black scar you were just on.
What?
Here.
It's supratemporal in
Anthony,
the
where'd Mama
fundus
go?
at about 2 o'clock. Yeah, right there.
Yeah, what is that, Catherine?
Okay. Thank you.
Is that some intraretinal hemorrhage? I can't see it. It looks kind of blurry on my screen.
So if you're trying to figure out what's going on, is there any test you might want to do on this man?
You can get an FA.
Okay. What do you see? Let's call on, let's see, is Andrea Arteaga there or Kevin Heinze? Read out your
I'm
scene.
here.
Andrea, what do you see?
So on the fluorescein on the right eye, so the picture on the left, you can see the same images that Catherine was mentioning, the C-fan. You can see it nasal to the nerve, yeah, with some areas of leakage. You can also see the AV anastomosis. So yeah, all those are your pointing. There's some more inferiorly. Hello? Hello?
Yeah, we can hear you, Andrew.
Oh, okay. Sorry. Okay. And then there's some other areas temporally that we can see, yeah, right there. And also some areas of ischemia. We have capillary dropout. Yes, all over there. Yeah, but I don't see any blockage or leakage in the macula. I don't know. I know that we saw some changes in the macula in the color photo, but I don't see anything here. I don't know if
Hold that
it's just my
thought.
screen.
And so here's the let me show you the other eye. Okay, so this is the left
Okay.
eye now.
So we also see multiple areas of like the C-fan with leakage right there, and inferior lead 2, and then superior, yeah, all this
What
AV
is
anastomosis,
Good.
all those. Yeah, I can see multiple areas there, and maybe a little bit of capillary dropout, more peripheral there.
Here as well as there.
Mm-hmm.
Okay, Dr. Goldberg, do you want to comment on the fluorescein in this patient at all? Or do you think?
Sure. First of all, the fan-shaped configuration is pretty typical, as one of the former speakers said. And yeah, that's a good one. With an AV connection and a fan-shaped neovascular lesion that leaks at its peripheral borders due to aneurysmal dilatations, indicating that the whole lesion doesn't have a normal blood retinal barrier. And I can't miss the opportunity of reminding everybody that the blood retinal barrier, due to tight junctions in the endothelial cells, were first described by an infirmary, former infirmary faculty member, Jose Cunha Vaz from Portugal. He described the blood retinal barrier with electron microscopic characteristics, that is, tight junctions between endothelial cells, when he was only 21 years old and a PhD student with the great Sir Norman Ashton in London. And Professor Cunha Vaz, still at the age of 80 plus, is active in Portugal and still doing great research on retinal blood vessels, particularly in diabetic retinopathy. But here's a good example of no blood retinal barrier. And over time, with a passage of a minute or more, tremendous leakage across the defective blood-brain barrier into the vitreous. So there's chronic transudation of plasma and plasma proteins into the vitreous, leading to syneresis of the vitreous and ultimately collapse and traction. And that's a problem because whenever there's pre-retinal neovascularization, regardless of the disease, regardless of the etiology, there is immediate adherence of the new blood vessels to the cortical vitreous. So when the vitreous inevitably condenses, collapses, and engages in traction, those fragile new formed blood vessels easily bleed, and even a tiny bleed can cloud the vitreous sufficiently to impede visual acuity. So vitreous hemorrhage is bad. Transudation across defective blood retinal barrier is bad. And so you have to decide whether or not you're going to try to get rid of those neovascular proliferations. And Jenny, I don't know whether you're going to talk about that issue, but maybe you can tell us what you think the proper, once you make a diagnosis, of course, what you think about intervening therapeutically.
Right. So I will get to that. I do want to go back one moment though, because Andrew did point out that the macula was abnormal, and I think you had pointed it out also, that there was some macular reflectivity abnormality. So the OCT was taken on this person, and you can see the right and the left eye. I'd like to call on Sean Gulati to just overview and tell me what you see here on the OCT of this patient, and what do you think happened? Remember,
Yep.
2020 patient. 2020.
So, can you hear me?
Yes, yes.
Okay, so on the left side, there's a OCT of the macula of the right eye. I don't see any vitreomacular adhesion. There's no more foveal contour, but then temporally, it looks like there's a sharp demarcation of retinal atrophy that you can see in the lower photo as well. And then in the right photo, there's another OCT of the macula of the left eye, and you see the same sharply demarcation of retinal atrophy temporally.
Why do you think he has this?
I think this is due to like the diagnosis we've been discussing, sickle cell retinopathy and vascular occlusion causing that temporal retina to become atrophic.
Right, and that would also give the abnormal reflectivity. Is there a clinical sign that can go along with this? When you look clinically at a patient and you see a decreased reflex, is there a name that we put with this? Any of the residents? This was described at the infirmary as well.
Like a foveal depression sign.
Correct, foveal depression sign. Dr. Goldberg, you want to comment on this part?
Well, I think, yes, it was indeed first described in the infirmary by Dr. Michael Goldbaum, and wrote a paper 35, 40 years ago entitled The Depression Sign. It looks like a foveal light reflex, except it's eccentric to the center of the fovea. And of course, the other thing you Jenny, and the residents at the Illinois department have published the first observations. This is not a classic example, but the phenomenon of the splayed macula, in which there is no good foveal depression, as seen in OCT, in a more saucerized appearance rather than a deep foveal pit. All these things, all these observations were made at the infirmary by residents and faculty, and they have remarkably stood the test of time for close to half a century, just about half a century. It's unbelievable to think about it. But even with new sophisticated testing technology like OCT, those original observations made with an indirect ophthalmoscope have remained valid.
Exactly, and I have some examples of that later.
Can I make a quick comment?
Yes, Kirk.
Just for the residents too, you know, the easy part of being an ophthalmologist when we examine a patient is to use an instrument to shine light at the tissue directly and looking at it. So whether or not it's at the slit lamp, you can dial the light against the iris or lens, or the cornea, same with the retina doing biomicroscopy. The next level of skill up that a lot of people just pass by completely and maybe go through their entire career with never mastering the skill is looking at reflected light. In the cornea, for example, it takes a skill to look for guttata. Joel's on the line here and knows that specular reflex is reflected light off little crescents of where the guttata are adjacent to areas that dip down that reflect the light differently. And again, that's all about looking at something that you're not accustomed to looking at. In the retina, this is a great example of seeing pathology because of the way the ILM is reflecting it abnormally and creating what Michael called the depression sign, as Moore mentioned years ago. I use that reflected light all the time with silicone oil in the eye. You can see, because silicone oil really highlights the ILM, and just pay attention, it's right there in front of you, of what the light looks like against the macula. You can see epiretinal membranes become more visible. Vinny Rapucci in New York actually used that technique to peel the epiretinal membrane, looking at reflected light under PFO rather than staining it. So again, I encourage the residents that there's so many, especially at the slit lamp. The slit lamp is such a marvelous instrument, and there's so many different ways to look at the illumination, and reflecting light off things is a great way to see things that you wouldn't normally see.
Exactly right. And especially for the retina, for the residents, you might not think the slit lamp is useful, but it is exquisitely useful, especially for examining patients with sickle, as we'll see as we look at some other images. So this patient was reimaged 15 months later, and you can see it looks about the same, but if you do quantitative measurements, the retina actually has thinned further over time, and we'll go into that. So this particular patient had some fibrosis, I thought, Dr. Goldberg, and with the fibrosis and the lack of the active hemorrhaging, you could either treat with lasers, we'll discuss later, or you could observe this patient. And this patient, we went ahead and observed, and he actually did well. If he were unreliable, if there was any activity, active blood, we would definitely have treated, and we will go into treatment later on. This is just the OCT showing the thinning that happened over time in just a year's period, and these are real because as for the residents, you know, as faculty, you know, the OCT, we know that the repeatability is supposed to be within 1 to 2 microns at the most. So if something changes more than that, it's a real change. And you can see here that there's a drop of about 6 microns over a year in one eye, and then 2 microns in the other eye. And we have studied this over time in over 300 patients, and we are showing that actually it does decrease over time. So congrats to the residents because you made the diagnosis. I didn't have to go through the differential of what is peripheral neovascularization. I think you picked up on the classic CFAN that occurs in the periphery, and astutely also picked up that there's associated arterial occlusions, that there were AV anastomoses, tortuosity, as well as the other seminal findings of sickle cell retinopathy. I do want to draw your attention, residents, to these excellent papers, again, by former faculty at the infirmary, including Dr. Jampol, Dr. Michael Goldbaum, in the Survey of Ophthalmology that talked about peripheral neovascularization. I think these are really excellent review articles on what constitutes a differential in peripheral NV. I won't go into that today. Anyone pipe in if you have comments?
Well, one brief comment. So that paper, that key paper by Lee and Mike and colleagues was published 40 years ago. And I can't think of a thing to change in that paper, despite the accrual of a fair amount of new knowledge in the last 40 years.
Yeah, it seems like we're just getting new ways to image and basically corroborating what you all found back then in changes and just being able to quantitate it a little bit more.
You know, I want to chime in one additional thing, Jenny, because it's something that infirmary residents, you guys are blessed by being at the infirmary for so many reasons. But, you know, that paper in the survey, classic paper, right? Required reading, but you can't get it online because it's that old. You got to go to this thing called a book to find paper and flip it open and actually read the damn thing. But the University of Illinois has an amazing library. And if you go to the library, it's a block away in the lower level. There's so many times that I would go over, Tom Deutsch and I would run over, we'd walk over there, and we would just grab off the stacks at random, Archives von Graeve from 1880, and just flip it open and look at it and just flip from page to page and see the things that people were writing about in the 1800s. Would blow your mind at the things that they were doing. How people were thinking about uveitis treatment in the 1920s by all these papers on extracting all your teeth as part of anti-inflammation. So you're at the Eye and Ear Infirmary, use the library and look up some of the old stuff. It's so cool to look at these old ones. I remember, like it was yesterday, picking up Carl Stargart's original article with a hand-drawn drawing in a bound journal at the University of Illinois Library. It's such a great resource, and it only exists there, and over at ICO has a great library too. But you guys got to make sure you use the library there.
Right. Those were the days of Mary Winnicky, and today residents, Mary Winnicky, fantastic human being and person who helped with lots and lots of papers that we all wrote as residents. We also now have Margaret Chervinko, who is an outstanding librarian, helps me numerous times, and she can get stuff like this for you and can PDF it electronically so that you can have this on file. So I actually have this electronically if you all want it. I do want to say, Dr. Goldberg, you might not know this, but when you used to give us reviews to do, because they used to come in an envelope, and it was an honor to get a review to do for the archives. Remember that, Kirk and Peter Panton, everyone else on the call, Nancy Hemming. We used to get these, and then what we would do is we would look up every single reference and check every reference, because that was what, quote, that was what Mort expected. So we used to go beyond, because we knew that's what was expected. And we wanted to do it because we wanted to do well, because we knew Dr. Goldberg expected that of us. And it goes to say,
and it's a great way to get educated.
Yeah, well, yes, right, exactly. And because of that, we learned a lot, and we thank you for that. So getting back to this patient, there's is excerpted from the family tree. This is actually pulled from the chart. That's why it looks the way it does. It was scantily drawn here when I was in a hurry. But when you see these patients, you got to draw out their family history for any of these genetic diseases. Draw them out, and so you can see here that this is the index patient. He has three younger brothers, and has another brother who has SC, and then two others that have trait. So that's the tree. A lot of other times it works out perfectly. In this case, it ended up being 50%. Residents, what would you expect with this? With the traits, you'd expect 1 in 4. Unfortunately for this family, 2 in 4 were involved. This particular patient admitted to 1 to 2 crises per year about every 6 months. no hydroxyurea was required because he was an SC as opposed to an SS patient. And he had actually no systemic associated complications. And we're going to go into the vagrances of sickle cell retinopathy here in a moment. So this is just, yes, Nita.
Question. Did we think the hearing loss from this patient?
Thank you for reminding me. So when we looked at our sickle patients, they do get also infarcts in the cochlear area related to sickle, but this is a red herring in this case. This gentleman had a sound trauma. He had had earphones on and somebody put the volume really loud. And so he damaged his eardrums bilaterally, was put on high dose prednisone, and eventually recovered the hearing in the left, but not the right. And perhaps because he had sickle, he was more predisposed to have some permanent sequelae from that sound trauma than he otherwise would have. But there is an association that we found looking in our chart reviews of some hearing loss as well. It's been reported. Dr. Goldberg, did you want to comment on that?
No, carry on, Jenny.
Okay, so sickle cell disease is, to me, fascinating disease for many reasons. Obviously, it's endemic in malarial areas, and the reason is that they found recently that there is less death if you have sickle cell because you don't get the cerebral malaria. You can survive that. It has to do with carbon monoxide and oxygen levels, so that explains why that happens. It used to be that the life expectancy was decreased by 25 to 30 years until the development of drugs like hydroxyurea. And so now we're seeing sickle cell patients living into their 50s and 60s in my patients. And there's also, I don't have time to go into it today, but sickle cell transplants in which we can cure sickle cell. And most recently, there's been a CRISPR case where they've actually cured sickle cell also from a genetic standpoint. So it's fascinating. It was the first identified genetic disease by Linus Pauling in 1945, although it was first reported in 1910. So it took another 35 years to figure out that it was genetic.
And that was the paper in Chicago too. That was
yes.
John Herrick was over at Rush, and Rush in 1910 was basically combined with the infirmary back then too. So again, even the original description, it was called, his title of his paper was great. And again, it's in the library in the lower level if you want to go look it up.
Okay.
Is unusual corpuscles in an intelligent male Negro. And I thought, how politically incorrect is that as a title of a paper?
Right.
But that was John Herrick in Chicago that did that.
And the first peripheral fundus change was described by Cook in 1930.
Yep.
So, it's just a fascinating disease with a very rich history in the Chicago and infirmary Rush tradition. So today, I know we're running out of time, but I want to go through the staging of sickle cell retinopathy, the treatment, some insights from imaging, and lastly, some artificial intelligence stuff that actually is also being found to be useful. A lot of the seminal work in sickle cell came out of the infirmary through the leadership of Dr. Goldberg. I'm going to go ahead and dive right into that. So sickle retinopathy residents, when you want to go ahead and describe what you see, you want to put them into two categories, non-proliferative sickle and then proliferative sickle findings. So first, when we look at the non-proliferative, you look at the vasculature, you'll see tortuosity. This has to do with the sickling of the cells and the vascular hemorrhagic changes that cause shear forces, etc. You can also see sickling on the optic disc. This is a paper from the disc sign in sickling hemoglobinopathies, again by Michael Goldbaum, Lee Jampol, Morton Goldberg, heavy hitters, back in, that should be 1978, not 1078. And you can see here these transient little dots that come and go from sickling within the optic disc. I find personally this is a little bit hard to see. You have to be patient to look at the disc. So I don't often look for this, but if you sit there and you look for it, you'll see it. And they change, right, Dr. Goldberg? They come and go.
Yeah, and because they're transient, they don't interfere with the visual function of the optic nerve.
Good point. And then here's a beautiful example of the foveal depression sign, exactly what Kirk Packo was saying. Because of the reflexes that are coming off from light, you have more of an excavation around the edges. So you get this parabolic area here of thinning, and you get a dark area of the light reflex here. That is the foveal depression sign. There's also vascular occlusion that occurs. And conjunctivally, you can get these, sickled comma vessels. But I wanted to show you this paper, which is a beautiful paper, really, by Don Galliano, former Retina fellow here with Dr. Goldberg. And they show the evolution of a salmon patch hemorrhage to retinoschisis with iridescent spots, as well as to the sunburst lesion. So prior to this, it was postulated that if you have sickled cells in an arteriole, it can cause a blowout of the arteriole and you can get blood into the retina, sometimes underneath the retina, sometimes on top. The blood will look as such, it'll be bright red, and then it will turn this orange-red color within a few days, hence the salmon patch. Over time, it can turn yellow, and then it can resolve either as a schisis cavity or as a sunburst lesion due to the irritation of the RPE. It's a reaction to the blood deep in. And when you have the schisis, you have these copper-colored granules that are iridescent. And what those are hemosiderin-laden macrophages that are within the schisis cavity. And you can see them here, these little iridescent little spots. Comment, Dr. Goldberg or Kirk?
I was going to ask Mort, what, you know, we see hemorrhages all the time, sub-ILM hemorrhages from all sorts of things, Valsalva, diabetes, and it never gets that orange color. It's almost pathognomonic of sickle. Well, why does the sickle hemoglobin give it that orange color? Or is it just because that's what it does?
Just because, Kirk, that's a great way to think about it. I don't know why it's so characteristic of sickling, but not of other lesions, but they are typically restrained from breaking through into the vitreous by the internal limiting lamina. And since they sit there without moving for a long time, the blood hemolyzes, and the combination of the white hemolyzed red cells and the still unhemolyzed red cells, that combination of red plus white probably gives this salmon-like coloration.
Do you think it has to do with the thickness also of the hemorrhage? They tend to be thicker too, I find, than just a regular hemorrhage.
Yep, that's true.
Okay, and so this is a question for one of the residents. Ricky Cooey, are you on the call? Or Kevin Heinze, second years? Aaron Kaufman?
Yeah, I'm on the call. This is Kevin.
Kevin, all right, great. What do you see? Look closely here at this picture. This is a sickle cell patient. Don't tell me about the tortuosity. Don't tell me about the foveal depression. What do you see?
I mean, there's definitely some attenuation. There's some atrophy around the disc as well.
You're in a good area to look. What else do you see?
Is it like these streaks coming off?
Beautiful. What type of streaks are these?
These the angioid streaks.
Right, angioid streaks, so named because they look like vessels, but they're not. They're angioid-like. Is this common in sickle cell, do you think? We'll ask Dr. Goldberg that question because he's published on this as well. And here's his paper with Dr. Nagpal, Astorian, Apple, and Goldbaum again, looking at the prevalence of angioid streaks. And I believe before this paper came out, people had said anywhere upwards of 2%, some said even 10 or 20%. But you then studied a total of 356 patients and looked at all of these images and found that the actual incidence you think is closer to 1 to 2%. And like Kirk, I'm going to ask you, do you think it's because the Brooks membrane is more fragile, maybe from hemosiderin-laden changes from bleeding, or what is it that causes this, in your opinion?
Well, at one time I thought it was deposition of iron, free iron in Bruce membrane that made Bruce membrane more brittle. We finally did have an opportunity to look at a nucleated eye, or maybe a post-mortem eye from a homozygous sickler who had clinically diagnosed angioid streaks. And there was no iron. It was all calcium, just as in pseudoxanthoma elasticum.
Morton, I think I'm correct in saying this, but you know, the residents know the list for the OCAPs of all the causes of angioid streaks, right? And they're all calcium problems. I always thought too, iron is right below calcium in the periodic chart. I thought maybe that was related too, but it's all calcium related. And all of them can give rise to choroidal neovascularization. Now, as far as I know, the angioid streaks from sickle has never been associated with choroidal neovascularization, where all the other angioid streaks have been. Have you
Yeah.
ever seen choroidal
No,
neovascularization?
I think your observation is correct. It's an unknown issue. What protects these eyes against choroidal neovascularization? I have no idea.
Interesting. Do you think that they're just so infarcted that they can't produce the VEGF to cause it? Because it's just,
Or if they do start to grow, maybe they sickle and occlude.
they sickle,
right
that's
from the
due to
get-go.
an autoinfarct in the back.
That's probably a very good explanation.
Okay, so then we talked about the foveal depression sign, so we'll move on. This is just one of the first papers, again, residence. This was from a former resident and former fellow at the time, Donnie Hong and Felix Chow, working with Manoj Shahidi and me. And we looked at the correlation of the foveal depression seen here with the OCT and found exactly what Dr. Goldberg was describing earlier, in that you have thinning related to ischemia and you have what we coin splaying. In other words, a normal retina should be like this, but because there's ischemia and infarction, you get thinning at the edges and we get like a splaying, like you pull the wire apart. And so instead of a V, you end up with a more U-shaped appearance here. We also found some other areas elsewhere that also have focal defects of ischemia. And we also then later looked and we found that even in patients who are 20/20, that you can get this sort of subclinical foveal depression sign, and that we'll detect it earlier in the OCT. So the proliferative changes of sickle retinopathy were staged by Dr. Goldberg. I believe this was your AOS thesis, published in the 1970s, and we're going to go right into that. So this residence, you must know this, coming from the infirmary, you know it anyway. Regardless, Dr. Goldberg's classification of proliferative sickle retinopathy, American Journal of Ophthalmology, 1971, where he lays out in exquisite detail, very elegantly, the different stages of sickle cell and quantitations within each of those stages as shown here. Prior to that, and maybe Dr. Goldberg, you can give a little history. I know we're running long on time, but it's so rare to have this time to have this discussion with you.
Well, I remember doing this classification on my dining room table in Oak Park with about 100 black and white fluorescein angiogram prints to try to understand. And when I proposed that the first event was arteriolar occlusion, I did take a lot of heat from the acknowledged gurus. Here's a good example in the black and white photograph. Good evidence of just an arteriolar occlusion. Because the classic textbook on retinal blood vessels at the time, which was written by famous people like Paul Henkind and Wise and Colin Dollery from England. And in that big textbook on the retinal blood vessels, they clearly state that the first stage of sickle cell retinopathy is due to retinal venous occlusion. Well, that was logical, because sickling occurs when the partial pressure of oxygen in the bloodstream falls, which induces the sickling phenomenon. But it's a good example of just because something is logical doesn't necessarily make it so. They were dead wrong, and this is the type of angiogram that proved it. And if you wanted even better evidence, think about central retinal artery occlusion in young children, 5-year-old boys, 10-year-old children with homozygous sickling. They are the ones who get the sickling patients, are the ones who get central retinal artery occlusion, but not, very definitely not, branch vein or central retinal vein occlusion. And in the bad old days, we had founded the world's only, it's still the world's only, sickle cell eye center. We studied about 1,000 sickle cell patients at the infirmary. And although lots of them had retinal vascular occlusions on the arteriolar side, and half a dozen or so had central retinal artery occlusions, absolutely none, let me repeat that, absolutely none had branch retinal vein occlusion or central retinal vein occlusion. And to this day, I've never seen a sickle cell patient with a retinal vein occlusion. I mean, it's going to happen sooner or later if I live long enough, but it'll be sheer coincidence. This is a retinal arteriolar occlusive disease. The worst case scenario is central retinal artery occlusion in a child.
Thank you. Thank you, Dr. Goldberg. That's great. I didn't realize that history was there. And in the papers that you had published initially and true to form, again, most of these are in the temporal quadrants. The watershed zones are more affected. We find that also in the OCT, that there's more thinning in these areas that goes along with more occlusions in that region. Stage 2, then, after stage 1 arterial, stage 2 is arterial venous anastomoses. Here's a beautiful example of an anastomosis in one of our patients. Again, in the seminal papers, most of these were mostly in the temporal quadrant. If you look very carefully enough, almost 80% of patients have this, we find, and you have to use the slit lamp. You cannot see this unless you have, you know, Superman vision with an indirect ophthalmoscope. Again, Dr. Packo was saying how important the slit lamp is. This is one of those situations where when you're seeing the patient, you must use the slit lamp and the fundus lens to see this periphery. Here's the picture from one of Dr. Goldberg's seminal papers, again, showing the beautiful AV anastomoses here. And then this particular example from the Archives of Ophthalmology in 1971 shows a really cool picture, I think, because there's an arterial occlusion, there's an area of AV anastomoses, and then there's a C-fan. And I think, you know, stage 1 and stage 2 usually run together. So you got an occlusion, you have AV anastomoses, and it makes sense that you've got all this ischemia going on there, that's where the NV is going to sprout from also. Comment, Dr. Goldberg, Kirk? Anyone?
Oh, you said it very well, Jenny.
Okay, thank you. And then stage 3 is the C-fan. Again, beautiful example of a C-fan, and you can see the ischemia anterior to the C-fan. So residents know you're thinking now ischemia, you're thinking VEGF production, you're probably thinking, can you use an anti-VEGF in a sickle cell patient? So hold that thought. Here again, most of the C-fans were noted to be superotemporally in the disease. And then, as Dr. Goldberg already said, you get all of this change, you get vitreous traction. And this vitreous traction can be as gentle as a slight trauma in the eye. And if the vitreous pulls on that, you can get a little hemorrhage there. And typically the hemorrhages sit over the area of the C-fan, and that's why you get these salmon patches. They're held in by the ILM. But occasionally they can break through, as in this eye, and you can get a more severe vitreous hemorrhage, which is stage 4. You can see the neovascularization here, fibrosis, a little bit of a salmon patch, and then here more generalized stage 4 vitreous hemorrhage, again with fibrotic C-fans. And then the most severe stage is retinal detachment. And this typically will occur with a hole or a tear in an area adjacent to a C-fan where there's continued vitreous traction pulling on this, contraction of the neovascular tissue, and eventual avulsion from the vitreous of a part of the retina, and you get a regmatogenous component. Any comments, Dr. Goldberg?
No, you're doing great.
Okay, thanks. So then there was the Jamaican cohort study. Now, there were lots of observations that said that, you know, hemoglobin SC is more severe in the eye versus SS. And there are several theories as to why that might be, and I'd like to pick Dr. Goldberg's brain as to why that is. But before we get there, I'd like to call your attention to the Jamaican cohort study, which was done by Downs and Schwang. And what they did is they looked at 100,000 births in Jamaica between, I believe it was 1973 to 1981. And they cataloged everybody, and they picked out all of the patients who were sickle positive. And then they followed all of these sickle patients, sickle SS, SC, STHAL, and they looked at what's the prevalence in at age 20, what's the prevalence at age 10, what's the annual incidence. And what they found out was that the prevalence of sickle retinopathy occurred earlier in SC phenotypes than in SS. The earliest was, I believe, at age 8 in SC versus age 16 in SS, if you want to get the biggest spread of difference in proliferative sickle retinopathy. And the prevalence was also very different, 43% by age 20 for SC versus 14% for SS. And again, the annual incidence of progression was also linked to the phenotype SC. Also, the extent of abnormalities in terms of anastomoses, in terms of clock hours, based on what Dr. Goldberg described for staging, is also associated with progression to proliferative disease. So Dr. Goldberg, can you comment as to why SC versus SS and onto those theories?
Well, it's an enigma, but if I had to speculate, I'd say that it has to do with the fact that SS patients Well, let me backtrack. It's counterintuitive to think that the less clinically severe electrophoretic pattern of hemoglobinopathies, the less clinically severe systemic affected patients have the more severe retinal manifestations. But just like the idea that the retinal arteriole is the source of the primary event versus retinal venial, where it's not logical, I suppose, it's not logical to think that the less seriously affected, systemically affected patient has a greater chance of a serious retinal problem. It's just a matter of knowing that just because something is logical doesn't necessarily make it true. In this case, just to speculate, I think that the SC patients who have a higher hematocrit and therefore more whole blood viscosity tend to occlude their arterioles more frequently than patients with SS disease who are more anemic and have less whole blood viscosity because of their serious anemia.
Yes, I agree with you. And I think that also there's been some work, and I'm not sure if it was Jerry Luddy's lab that looked at this too, where they found some endothelial adhesion difference between the SC phenotype and the SS as well, that perhaps they're more prone to getting vascular changes in the retina. So there's also this talk of the border in terms of a prune shape where you have this abrupt pruning of the vasculature as opposed to more gradual AV anastomoses in the periphery. And if you have this abrupt pruning on your angiogram, that too is a risk factor for progression. And that's called the type 2A Penman border that's been described. So now we come to the question, do you treat or do you not treat? Okay, so if you look here at 5A, you'll see this is an example of an 8.5-year-old girl from the Jamaican Cohort study who had this area of neovascularization. Now, they repeated the exam only 8 days later, and you see there's nothing leaking now. All of a sudden, it's gone. Then now you repeat it a year later, and you see growth of the neovascularization with further extension, and then the other eye also gets neovascularization. Here's another example of a 24-year-old man with SC disease who has extensive leaking, shown here with the C-fan, and almost complete autoinfarction on follow-up 2 years later. And then you go back in follow-up, and then the neovascularization recurs. So this was a problem when you're trying to figure out in a sickle patient, do you treat them, do you observe them? Because there is a spontaneous regression that occurs in approximately 30% of sickle cell patients. So do you need to treat them or not? And how do you treat them? And so the infirmary was one of the places that, again, was leading the way here in terms of treatment. Cryotherapy was tried, feeder vessel technique was tried. Feeder vessel technique, I believe, Dr. Goldberg, you had described this also. Currently, unfortunately, it's antiquated because it was difficult to master and it had some complications. But I remember watching you do this when I was a resident. And it's a very tricky technique because you have to close off the blood flow to the vessel, the feeding arteriole and the draining venial. And residents, think about what order you might want to do that in and why, obviously. So you want to cut off the feeding arteriole before the venial so you don't get the thing blowing up, right? If you close the vessel, the vein first. So subsequently, at the infirmary again, a study was done called the focal scatter laser trial, in which they surrounded C-fans with a focal scatter pattern. And the idea was to see if you could, if you will, perform a almost PRP-like limited treatment to the area where the neovascularization was. And in the study, this was done. And they found that if you treated the patient, you had complete or partial regression of the C-fans in 81% of the treated versus controls, which regressed 46% of the time. So this was due to spontaneous regression. Now, complete closure only occurred in 30% of the treated and 22% of the control eyes. So why would you then do this? So you want to treat a patient because you want to prevent visual loss or things that can impair vision. So if we look specifically now and we look at the percent of eyes that experience any visual loss, you see that this dashed curve here is the rate of cumulative experience of visual loss over time in an eye that had no treatment. So this is a control. So you see lots of eyes falling off here, whereas the eyes that had treatment had much less visual loss. Now, if we looked at the percent of eyes that experienced visual vitreous hemorrhage, we see overall it was 11% of treated eyes versus 18.7% of control eyes. But what you have to ask yourself is not just the raw number, but you have to control for the amount of neovascularization at baseline and vitreous hemorrhage at baseline. And when you do that, you see that there's a significant difference in that the control eyes did worse than the treated eyes. And so therefore, despite the high rate of spontaneous progression, because the treatment is well tolerated and because you can prevent visual loss and complications of vitreous hemorrhage, we do recommend focal scatter laser treatment. But even when you focal scattered patients, they still develop new CFANs, 34% in treated and 41% of control eyes. So this was also an enigma. Why is this happening? Well, as you might guess, these sickle patients continue to get areas of ischemia, and they can form new areas that release VEGF. But in addition, there was a post-mortem study done, again, by Dr. Goldberg's group, this time more recently in 2016. And they looked at the VEGF and the HIF patterns in areas adjacent and anterior to CFANs. And they found that it was actually a 2 millimeter region around the CFAN. And so this may help explain why when we laser patients, you get complete regression only in about a third of patients. And perhaps a more generous application of laser would be recommended. So having found that out, Dr. Goldberg, how would you recommend we laser now for sickle patients?
Well, you've given a great review of the literature. There are a lot of faults with these studies, and I'm partially responsible for those faults, but for the moment, it's the best data that there is. First of all, I don't think it's necessary to do a prophylactic peripheral photocoagulation when they're only stage 1 or stage 2 lesions. They can be followed expectantly. As far as stage 3 lesions, if there's any evidence of bleeding, that is to say, if the disease has already gone into stage 4, well, I think photocoagulation is indicated in the way you described. Large zones of scatter photocoagulation around each neovascular patch. Furthermore, if there is obvious enlargement under observation of CFANs, or if they're very heavily under traction and therefore standing straight up into the vitreous chamber, they're at risk of bleeding because of the severe traction, and I would photocoagulate them as well. On the other hand, if you have a small, solitary, naked neovascular frond flat against the retina, particularly in a young person who might otherwise need general anesthesia to undergo photocoagulation, I would not recommend treating those kinds of patients. But if there are multiple large CFANs under traction, already bleeding in one eye, I would bite the bullet and do the type of enlarged focal photocoagulation by the scatter technique that you described, Jenny.
Jenny, I want to make a comment too. Is that once you get the treatment in, and as you commented, they can get new CFANs later, even if you've done this. You still have to follow these patients. It's not just you do it once and you never see them again. And this is something that I learned from Dr. Goldberg. It's something 40 years later I still do. I do it exactly the way he did, and something that residents do so little of, and it's even going to sound alien when I mention this. Mort had in his office, and right next to his slit lamp, you pull it open, there was a drawer there, and there was fluorescein. And he would inject the patients in his office. You don't have to send them for angiography. And we have the luxury of Optos angiography, but again, you got in practice, you may not have an Optos in your office. They're expensive, you not always have it. And all you need to do is inject the fluorescein, put your indirect on, put the blue filter in. And if you don't have that, sit them at the slit lamp and dial in the blue filter and look around. And you can find at least leaking CFANs. If they're infarcted, not leaking, you need not worry about them. But it's also great in diabetics that have a sea of pan-retinal laser and you can't find where they may bled from. And again, it's something I learned from Dr. Goldberg. That's an infirmary tip that I still do 40 years later, and I have fluorescein in my exam rooms that I use occasionally because of what I learned at the infirmary.
Well, I always listen to Dr. Packo, and that was good advice. So-called fluorescein angioscopy. You will see a green cloud of dye leaking into the vitreous, even if the media are otherwise hazy from a vitreous hemorrhage or a cataract or God knows what. It's a terrific technique. Almost nobody does it anymore, but it is very, very valuable.
Do you ever recommend oral fluorescein at all nowadays, or no?
I've never had the need for it, to tell you the truth,
Okay.
but if necessary, sure.
Okay. So anti-VEGF, there are only anecdotal reports of using anti-VEGF treatment, and I'd be a little bit worried about injecting an anti-VEGF in these eyes because of the fact that you could have such an abrupt closure of the C-fan that you could get vitreous traction and result in some complications. That being said, there have been some case reports as shown here, and you can see an eye from the first report in which bevacizumab was injected, and within a week there was decreased leakage, and within a month complete regression. And then this group went ahead and performed laser to the ischemic retina. Others
Jenny?
also in anecdotal reports as well. Was somebody?
Jenny?
Yeah,
Yes, Michael.
Yes.
I've done this on occasion when I've seen vitreous hemorrhage, and I'm concerned that there's going to be more bleeding. So in a diabetic, I will give them an anti-VEGF injection, and then several days later be able to complete the PRP. There is one caveat. I'm concerned about the transient increase in intraocular pressure. And so in these cases, I will also do a paracentesis so that the pressure stays the same. And along those lines, I don't know if you're going to get to it, I want to ask Mort, do you still recommend exchange transfusions when you buckle a sickler patient?
Well, the quick answer, Mike, is no. Modern vitreoretinal surgery, thanks to Kirk Packo and others, has improved so well that the need to do a partial exchange blood transfusion preoperatively is gradually faded into history. On the issue of bevacizumab, there's no doubt that the neovascular tissue will shrink away almost within days. It'll eventually come back. So we use it primarily preoperatively, 2, 3, 4 days before doing a vitrectomy or a buckle on a patient with neovascular tissue. We will inject Avastin and then be sure to be able to operate within several days because reperfusion can occur. And there is a so-called crunch phenomenon in which the pre-retinal neovascularization undergoing involution causes traction and possible tear formation and worsening or induction of a retinal detachment. The real problem with anti-VEGF therapy, it seems to me, is the one of follow-up. Getting a lot of sickle cell patients to maintain their follow-up appointments is frequently very, very difficult. And injecting an anti-VEGF into a neovascular sickle cell patient is not a one and done phenomenon. You do have to follow them up. You do have to retreat. If it's Avastin, you have to retreat with Avastin as the months and years go by. And that's a colossal nuisance for a lot of patients who cannot keep those follow-up appointments. It's a lot like the use of Avastin or other anti-VEGF agents in proliferative diabetic retinopathy, which seems like a very good idea, except at Wills Eye Hospital, people have found that the dropout is so high, the follow-up is so poor, that there's frequent recurrence after anti-VEGF therapy in the diabetic patient population, and they get out of control without the proper follow-up treatments.
Thank you. And so this segues nicely into the retinal detachment repair, where you want to avoid scleral buckling because this can contribute to anterior segment ischemia and elevated IOP. And as Dr. Goldberg says, we do not recommend exchange transfusions any longer due to excellent vitreoretinal techniques. The most important thing to remember when you're doing the vitrectomy, aside from, of course, great tissue dissection and laser of the ischemic retina, is that you have to ensure that the IOP remains low during surgery so that you don't cause a sickling crisis within the retina or induce sickling and get ischemia, because these eyes are a lower threshold to that. In addition, you want to make sure your patient's well hydrated and is also kept warm. And of
Well,
course,
can I just interrupt for a second?
yes,
It's really important if you're operating these patients by either buckling or vitrectomy or combined vit buckle to keep the pressure low, as you said, Jenny. Absolutely critically important to keep the pressure low and hyperoxygenated. So the anesthesiologist has to be told by the ophthalmologist to maintain high levels of oxygen during the operation, but then his job is not over. The levels of oxygen have to be maintained post-operatively in the recovery room for at least several hours and ideally for a day or two, because as the pressure goes up, the eye can undergo a sickle cell crisis and cause anterior segment necrosis. And once that happens, treatment is almost universally unsuccessful, and those kinds of eyes end up in ptysis. So maintaining low pressure and high oxygen are absolutely critical, both during the operation and very, very importantly, after the operation.
Mort, I did a vitrectomy on an SC lady, a nurse, about 10 or 15 years ago, and I wrote for my usual thing of mask O2 on the way to recovery.
Good.
Continue oxygen in the recovery room.
Great.
And I did my next case, and I got a word that the woman was in a lot of pain. So after I finished up the case and went in there, they had no oxygen on her. And the nurse said, "Oh, we thought you were kidding because you never do that." And she got anterior segment necrosis and lost the eye because that I think didn't have oxygen, and it was a vit. It wasn't even a vit buckle. So it just shows you how sensitive they are, and it's a big deal to get them to get a tank of O2 on the way to recovery room and keep it going there. But I think it's really important because of those swings in blood pressure and the swings in eye pressure too that can happen. Really, really great point you made there. It's really important to do that.
yes, very, very important. And residents, if you want to see how bad anterior segment ischemia is, you want to look up this paper by Steve Ryan and Dr. Goldberg from the AJO in 1971, where they describe anterior segment ischemia after scleral buckling, and you can see what happens to these eyes. It is not good, and they do lose vision, as Dr. Packo has said. So do remember those points. And again, this has been brought up already that you need to follow sickle cell patients. We generally follow them yearly. Usually the visual acuity remains good, but you do have to look for ocular infarcts, and after treatment, you need to continue to follow them because they do form new fronds. In the remaining few minutes, I'd just like to delve into some ocular imaging and show you how useful this can be. So in children especially, it might be hard to get a good look, and wide field imaging has really made a difference in being able to image that peripheral retina. And here's just a beautiful example too of some peripheral abnormality that you can see with wide field angiography as well. So we studied lots of patients with SDOCT, initially describing the splaying, and then we later examined 513 sickle eyes, compared them to 75 control eyes at baseline, and showed that the retina was indeed thinner in the sickle compared to control eyes, which reflects this subclinical infarct they're having in their retina, as well as elsewhere in their body. And we also showed that the thinning was correlated with the Goldberg stages of proliferative sickle retinopathy and inversely correlated with age. In other words, this is progressive over time. We suspected the older the patient, the more thin the retina, if we look at quartiles of thinning. And we've just recently evaluated our longitudinal data, and it bears it out. There is thinning over time that occurs. In addition, we found that there is thinning associated with systemic illnesses that are more severe. And interestingly, we found optic nerve thinning. So there was always this, Kirk, you probably remember this too, in the patients who have hyphemas who would come in. There's certain rules, right? The 25 pressure, the 50 pressure, and we always wondered, well, why was that? Why did you have to intervene sooner in sickle patients with hyphemas? Well, what we found is that the RNFL is in general thinner in sickle compared to control eyes, and over time it continues to thin. So I think these eyes have less reserve, and they're more at risk for infarcting and losing the tissue that they have because of subclinical infarcts. And Dr. Goldberg, I see you there wanting to talk about your rules, so go ahead and tell the residents what they are for the hyphemas.
Which one, Jenny?
Both of them, you know, the 50 at 50 rule and the yeah.
Well, the basic principle is that, as you pointed out, sickle cell eyes are much more at risk of infarcting with only mild to moderate elevations of intraocular pressure, particularly if the elevation is sudden, like associated with a hyphema, either a surgical hyphema or a traumatic hyphema. And patients who even have the carrier state, the sickle cell trait, AS hemoglobin, are at risk of losing their optic nerve perfusion and their retinal perfusion with only slight to moderate elevations of intraocular pressure. So ordinarily, my rule of thumb is to do a paracentesis or some other abrupt intervention in the presence of a hyphema in sickling patients when the pressure hits 24 or higher. It's an urgent situation. It sometimes can be a minutes or hours count emergency to reduce the pressure and thereby increase perfusion. The idea in this whole scenario is to maintain normal ocular perfusion, not just the retina, but also in the anterior segment. Otherwise, you're going to get infarcted tissue. And once that happens, there's really no reproducible way to reverse the problem. So early intervention by sudden decompression of the eye, that seems to me to be a very good idea.
You know, Mort, you pointed out in your paper that AOS thesis nicely that we think that you need to intervene 24 for 24 means you got to take them to the operating room to rinse them out. And what you showed, and I've seen it work for sure, is just a simple paracentesis, 30 seconds at the slit lamp, is that sudden decompression back flushes the meshwork, and you don't have to go to the operating room to rinse them out with a lot more morbidity to it.
Good point. Thanks, Kirk.
Great. And so we also know that these areas are thin. So the question is, if the retina is thin, so what? Does it really matter? So we wanted to find that out, and we've shown that if you do microperimetry, you actually have decreased function that correlates with the area of retinal thinning. So there is a reason why you want to follow these eyes. And there'll be patients who come in and they're not quite able to say what's wrong. And you'll look and you'll see that there's some thinning in part of their macula, and that corresponds to why they're not seeing properly, why their vision is a little bit off, because their function is decreased and they're not able to pick up the acuity in those parts of the retina that they normally would have. I'd like now just to show you some OCTAs. We also find now that the OCTA is actually more sensitive than OCT in distinguishing sickle from control eyes. And in fact, many other groups have worked on this. And Minvale, in a study of asymptomatic sickle patients, showed that yes, indeed, the FAZ is larger in sickle than in control eyes, and the vascular density is lower for the superficial and deep layers in sickle versus controls. Powell in adolescents has also shown that you have flow voids in the superficial and more in the deep layers, again in asymptomatic adolescents. Sally Ong from Hopkins was a fellow there with Dr. Goldberg and others, has shown that the OCTA in children is also abnormal even before you see changes on the OCT, suggesting that the vascular insult precedes the structural damage. So it basically supports everything that was said early on with the staging of the sickle retinopathy and subsequent thinning. Our group has looked at quantitative changes in sickle retinopathy initially with this paper by Minhaj Alam, who is a talented now PhD. He got his PhD this year, working in the lab of Xincheng Yao together with Dingkai Kao and myself, looking at quantitative characteristics. And we've basically shown that these changes, some of which were pointed out by Catherine in the first patient, tortuosity, the blood vessel diameter, and then we looked at the foveal avascular zone, contour irregularity of the FAZ, parafoveal density of the vessels, and the vessel perimeter index. We've shown that these change in sickle compared to control eyes. I'm not going to go into all of them. I'll just show you an example here of blood vessel tortuosity. And we found that in sickle that it was much higher. It was found at about 48% versus 31% of age and race matched controls. And you can use these changes, these variable changes in all these 6 categories to distinguish control from stage 2 and to distinguish control from stage 3 sickle cell eyes. And looking at artificial intelligence, you can show that the sensitivity when you use these parameters is good enough that a machine that is pre-programmed with this machine learning can distinguish that this is a sickle retinopathy eye versus a control eye. And it can also distinguish, is this a mild versus a severe form of sickle retinopathy? And more recently, we're also looking at differential artery and vein changes, and hopefully this will actually add to that ability to distinguish the stages of sickle and also distinguish sickle from diabetic eyes. And we have an R01 grant that's looking at that. So in summary, residents, don't forget to use the staging system of sickle cell. Don't forget the non-proliferative and the proliferative. Treat the stage 3 and higher using the caveats that Dr. Goldberg nicely enumerated earlier. Use OCT imaging to determine progression because it will change. You will see thinning, and that thinning may suggest that that patient is at higher risk for progressing and may also be linked with more systemic disease. So it could be a biomarker, we think. And we hope in the future to have some AI applications to help screen for sickle retinopathy and identify patients at risk for visual loss. This has been an enormously fun time for me to share with you. These are some of our grants. And just like Kirk, it's funny, Kirk, how we picked the same picture, except this is my class versus your class. And you see some of the luminaries in our field practicing in the Chicago area today and throughout the world. Here's our presidents of the academy, their former residents. It's really an amazing group, and chairmen in different departments. We all owe it all to this person right here, Dr. Goldberg, who inspired us, who taught us, who really made us become the best ophthalmologists that we can be, and gave us a great legacy in the infirmary and really in so many diseases, genetics, retinal vascular, you name it. Dr. Goldberg had his finger in the pot and made a seminal contribution to the field. And today I just wanted to highlight some of the contributions he made to sickle cell. This is when I was a fellow many, many years ago. So thank you, Dr. Goldberg. I say from the bottom of my heart, from me and all of your trainees, thank you for everything you've done for us.
And, if I could add one thing before you take over the mic, Mort. When I finished my chief residency, Jenny, Mort gave me a gift. It was wrapped up.
Okay.
And I thought it was going to be a gold watch or a trip to the Bahamas or something. And he dug down deep in his pocket and he gave me a signed picture of himself. But I'll tell you more, this has been sitting on my desk for 35 years and it's worth 1,000 gold watches. And it's been my inspiration, as it is for all of us, because we're all infirmary people. And we were driven to be the best ophthalmologists we could be because of the culture you created. So thank you very much.
Well, I have to express my gratitude for these wonderful, wonderful comments. And so if the truth be known, I have a signed picture from Kirk Packo on my desk. And I'm sure the audience has already concluded that they were subjected to a real treat today to listen to two world's experts in their respective fields. No one knows more about sickle cell retinopathy than Jenny. She's had an incredible career. And it's just one sidelight of her wonderful, wonderful set of contributions and innovations. And there's no one in vitreoretinal surgery the world over who's made as many innovations or taught so many people in such a pleasant, humorous, and lasting way than Kirk Packo. And you all have to know, if you haven't heard, that the distinguished society, the American Society of Retinal Specialists, have this very year inaugurated an endowed annual lecture called the Kirk Packo Lecture. It's the highest honor that a specialty society can bestow on anybody, and Kirk really deserves it. So all of us have to thank Paul Chan for listening to us for so long and having the wonderful attitude to bring us all together for an unforgettable experience, Paul. One of the most happy and delightful experience I've ever had. So thank you very, very much.
Dr. No, we have to thank you and Jenny and Kirk. I mean, this was beyond special to have so many wonderful alumni of the infirmary here and all our friends, you know, and this family here together. So thank you. Now, I know we're about an hour behind, and I apologize, Dr. Panton, for keeping you waiting. But Dr. Panton also had some words for you, some words of thanks, and also for our new residents. So today is July 1st, and the start of 12 new residents in our class. And, for those of you who want to stick around, please stay. But after this, we are going to give our Zoom reception just to introduce our new residents to our department and to our infirmary family. So Dr. Panton, you're on mute. There you go.
Okay, do you hear me now?
Yep.
Okay, I was asked by Dr. Chan to speak on behalf of our Alumni Association. I'm a comprehensive ophthalmologist in the western suburbs, specializing in cataract surgery. I know both of our distinguished alumni speakers quite well. Dr. Packo was my chief resident. Dr. Lim arrived at the infirmary 1 year after I left. Practicing in Chicago, I'm fortunate to have two such talented colleagues assist in the care of my patients. Our residents know Drs. Packo and Lim as world-class retinologists. Indeed, they are. I also know Kirk and Jenny as world-class human beings. Now, Drs. Packo, Lim, and I, and over 200 other residents and fellows, share the distinction of having been trained by our guest of honor, Dr. Morton Goldberg. When he arrived at the Illinois Eye and Ear Infirmary, it was a good place for clinical experience, but you needed to go elsewhere for rigorous scientific training. By the time Dr. Goldberg returned to Baltimore, he had built an elite academic department here in Chicago. In many ways, Dr. Goldberg has never really left the infirmary. The ongoing Goldberg legacy is manifest in his mentorship, as you've heard, his scholarship, his collegiality, and philanthropy in multiple dimensions. Now, we've all witnessed what it means to participate in grand rounds led by Dr. Morton Goldberg. Now multiply it by 52 weeks each year, and you know what an intellectual treat it was to be an IEEI trainee. On behalf of the over 10 score infirmary alumni who you mentored while you were in Chicago, we thank you for all that you taught us. If we have accomplished anything in our professional lives, it was because you were the person we wanted to emulate. Dr. Goldberg is the consummate clinician scientist. The range of his writings, as has been described today, is staggering. Ocular genetics, ocular trauma, sickle hyphema, sickle retinopathy. Now, what is his greatest scholarly achievement? While others may disagree, I feel that it's his role in the development of multi-center clinical trials is his greatest gift to our profession. I can offer a little perspective to our newest residents. I too invite you to go to the library and peruse our ophthalmology journals from the 1960s when Dr. Goldberg was a resident himself. The typical journal article described the experience of a single physician or a single institution. It was difficult to draw meaningful conclusions since there were no universally recognized definitions of disease. Randomization was unheard of. As for statistical significance, the phrase didn't exist in the lexicon of most ophthalmologists. Dr. Goldberg changed all of that. The first disease he approached using this new scientific paradigm was proliferative diabetic retinopathy, at that time a universally blinding disorder. In 1968, he convened a gold star panel of ophthalmologists. They met in Arley House, Virginia. Their classification of diabetic retinopathy with minor modification is the one we still use today. That first meeting led to other meetings as they mapped out a treatment strategy, first using a xenon arc, and then the recently invented argon laser. They agreed on metrics to assess treatment efficacy, and they agreed on a system of randomization. And they all agreed to follow the same protocol and let others review their records to confirm protocol compliance. All of this now sounds quite routine, but back then it had never been done. The multi-center diabetic retinopathy study, or DRS, was just getting started when Dr. Goldberg arrived in Chicago. The original coherent laser, which died when I was a resident, had serial number 0006. Many of the folks on this call probably remember that clunky laser housed on the second floor of the infirmary. But boy, did it work. The DRS proved, using valid statistics, that we could treat the scourge of diabetic retinopathy. More importantly, Dr. Goldberg had proven that scientific collaboration was the way of the future. Every randomized clinical trial in ophthalmology ever since has been modeled on the DRS. This type of science began with Dr. Goldberg and was first implemented at the Eye and Ear Infirmary. Dr. Goldberg built the first full-time faculty at the infirmary. Some of his colleagues remain to this day, Dr. Sugar, Walensky, and Miller. With Dr. Goldberg's encouragement, they participated in multi-center clinical trials in their own subspecialties. Our current treatments in herpetic eye disease, glaucoma surgery, and retinopathy of prematurity were based on studies conducted at the infirmary when Dr. Goldberg was chair. In my own field of cataract surgery, we forget that intraocular lens power calculations was once unpredictable. Another faculty member of the Goldberg era, Dr. Don Sanders, spent several years going over reams of cataract patient data. He did all sorts of linear regressions. Finally, that eureka moment arrived. All the characteristics of an intraocular lens, its optical design, its location inside the eye, and its refractive index could all boil down to a single constant in a linear formula. We now call it the A constant and the SRK formula, the only FDA-approved formula displayed on every IOL sold in the United States. That is the kind of research done at the Eye and Ear Infirmary during Dr. Goldberg's tenure that impacts millions of Americans today. When we talk about philanthropy, we usually mean bricks and mortar and dollars and cents, and Dr. Goldberg certainly did that. Our Lions of Illinois Eye Research Institute was built in the 1980s under Dr. Goldberg's direction. He raised all the money for Leary, either directly or indirectly through his partnership with the Illinois Lions. But the word philanthropy means much more than contributions. In Greek, philanthropy means the love of mankind. Dr. Goldberg's love of medicine and ophthalmology was infectious. Everyone who had the opportunity to work with him willingly caught that bug. We saw the greatest ophthalmologists of the last half century treat corporate CEOs and destitute residents of Chicago's West Side in exactly the same fashion. That is the philanthropy that Dr. Goldberg taught every one of us every single day. On behalf of the Department of Ophthalmology Alumni Association, I thank Dr. Goldberg for his service to the Illinois Eye and Ear Infirmary, his service in the past, and his service today. Thank you.
Well, I have to respond. I don't know how to respond, except I'm overwhelmed by those wonderful comments. Thank you, Peter. I said earlier today that my years at Illinois, 19 very special years, were the very best in my entire professional life, and it's quite true. Nothing before or since can compare to the wonderful, exhilarating feeling and comradeship that I experienced with all of you at the infirmary. It was a unique time. It was a treasure. It was a once in a lifetime, and I'm very grateful to each one of you for your friendship and your support and everything you have accomplished in your own lives. So thank you very much.
Thank you, Peter. And again, thank you, Dr. Goldberg. So at this point, we'd like to introduce our new residents. So I'm going to turn it over to Peter McIntosh, and he has some remarks for our faculty and for our residents.
Thank you, Dr. Chan, and thank you, Drs. Goldberg, Packo, and Lim for these great presentations, and most importantly for that great discussion that I know our residents really love. So we do have, let me just, here we go. Just a couple housekeeping items. That in order to claim your CME, you do have to fill out the evaluation. This is the first day that we've had CME for our grand rounds. And unfortunately, I think we're having a little issue with the link. So if you're having trouble, we might try to resend that a little later this evening. but please make note of the code 8390 because you'll have to enter that on the CME form in order to complete it and claim your CME. This is also for all of our residents and trainees that have to fill out the CME in order to track attendance. If you're having any issues, Tammy Maldonado is our program director and she can help you further. 8390, please make a note of that. That code changes every week, so that's the code for today. Okay, so I do want to welcome our new interns and first year residents. This is the first year of our integrated residency program. So the interns, which are the PGY1s, will actually be rotating with us 3 months of the year and then doing the rest of their internship at the University of Illinois. They actually started a week ago and our first year residents started today. So I just want to introduce them all to you and they're all going to then say, hopefully we can get it to work, just a few quick words to let you know a little bit something about them. So we'll start with the class of 2023. Catherine Chen comes to us from an undergrad at the University of California, Berkeley, med school UC Irvine, and then her internship at Harbor UCLA. And Catherine, are you there? Do you want to tell us, what are you eating?
Yeah, can you hear me?
Yes.
Just sharing a picture from my last trip. I love to travel and like explore and eat different foods. So this is from Japan. Getting some gyoza from a street stand back this last December.
Great. Hopefully we can all travel again soon, Catherine. Thank you.
Yeah.
Charles Frank, undergrad at Michigan, med school at Michigan, internship at St. Mary's in Livonia, Michigan. Charlie, tell us about your pictures.
Yeah, thanks. And thanks for really inspiring talks from everyone. Humbled and really excited to be starting. The picture on everyone's left, the patient's right, is a picture of me and my fiance at med school graduation a year ago. It is startling to see all those people standing so close to each other without masks. And the picture on our right here is me playing guitar and singing, which have both been a big part of my life for the last 10 years. Although you'll find if you search deep enough into the internet, videos of me singing a cappella in undergrad and in med school, rather than with the guitar.
Great. We'll ask you to perform at graduation next year.
Absolutely.
Okay. Catherine Lucarelli, undergrad at Wisconsin in Madison, med school in Wisconsin, her internship here in Chicago at President's Resurrection. Catherine, are you there?
Yeah, I am. Can you hear me?
Yes. Tell us about your picture.
Yeah. So I'm also really excited to be part of the UIC family, and this is a picture from my fall vacation last year. My boyfriend and I did a 4-day backpacking trip through Zion and ended, if anyone's familiar with Angel's Landing, usually people climb up it, but we got to descend down it, which was really fun. Great trip to the Southwest.
Great. And you'll see a common theme that many of our residents are very outdoorsy. This is one example. Thank you, Katie. Matthew Margolis, undergrad at UCLA, med school at Wash U, and internship in West Suburban in Oak Park. And Matt, what do you got here?
Hi, everyone. Glad to be here. Very excited to start. This is me last night after I realized I didn't have any pictures for the past few months since I've been crammed indoors. This is my rooftop garden. Hadn't been able to have one the last year, so tons of plants. If anyone needs any basil or pesto, I will have more than enough frozen for the rest of the year.
Thanks, Matt. I'm gonna take you up on that. Love cooking. Thank you. Next is Amar Sabah, undergrad at Michigan. We've got a number of Michigan alumni this year. Med school at Michigan, internship at Michigan. What are you doing?
Oh man, so you'll notice in the next 3 years, for some reason I always tend to be eating in all my photos because I'm probably always eating. So this is just one of those pictures that my friends always roast me on. So I figured I'd share the embarrassment with everyone today.
Awesome, good. Lots of good food in Chicago. You came
Oh
to.
yeah, can't wait.
And Sudhi Srivatsan, undergrad at Northwestern Med School in Michigan, internship also here at President's Resurrection in Chicago.
Hi, yeah. Can you hear me?
Yes.
Yeah. Hi, this is Sudhi. I'm also very excited to be here, excited to start, been looking forward to it pretty much all of last year. This is in last December, me and a buddy actually decided to drive up to Wisconsin, go to Devil's Lake and go kayaking. So we just kind of pulled a little off-road car action and got our kayaks out and went out for a ride. It was pretty fun.
Excellent. Lots of Great Lakes around. So that was our PGY2 class. Next, I would like to introduce our intern class. So they'll be rotating with us 3 months of the year, and then on various other wards on the floor and in other rotations. First, we have Louis Akaba Barakal, undergrad at Haverford College, Med School, Jefferson College, and the internship, of course, with us here at UIC. Tell us about your picture. Why did you show this?
Hi everyone, I'm Luis. Can you guys hear me?
Yes.
Okay, so I'm excited to be here. This is me playing tennis in college. I love playing tennis. It's my favorite sport, favorite hobby. So if anyone ever wants to play, just let me know.
Thank you. I think you're being, you haven't told us all the truth. I learned today that you're actually very good and ranked.
I mean, I guess I was, but I can play with anyone. It doesn't matter the level. I'll be just happy to get out there on the court.
Great. We'll take you up on it. Tala, she is UIC through and through, and I told her today for her fellowship, she might consider going somewhere else. But for now, we're happy that she's with us. Tala, your picture.
Yeah, thank you, Dr. McIntosh. Super excited to be staying on for residency. UIC is definitely home. And I'm really looking forward to working with everyone. So this is a photo of me flying my drone. It's a DJI Phantom 4 Pro, if anyone flies drones. So whether I'm traveling or even just, in the neighborhood, I like to capture things from above. This was actually when we went to Arvo in Honolulu. So this is where that picture was.
Great, we'll have to talk. We just got a drone that I'm trying to learn how to use as well.
Perfect, sounds good.
Jonathan Jeffers, undergrad, Harvard, med school, the University of Chicago, an internship, of course, with us. Jonathan, what are you up to?
Hi, Dr. McIntosh, thanks for that introduction. I'm really excited to be starting with you all, and very excited that we get to spend an extra year with everybody as well as the first intern class. But this picture is actually from last summer, back when we could travel a little bit more, but it's from Rocky Mountain National Park. I'm originally from Western Nebraska, and so growing up, I always loved going out to the Rockies and getting to spend some time outdoors, getting to really just be out in the mountains. And so I took this last summer with my wife when we went on a trip there.
Great, thank you.
Mm-hmm.
Mike Massengill, undergrad, University of South Florida, University of Florida, an internship with us. Mike, what are you up to here?
Hey everyone, can you hear me?
Yes.
This is me playing disc golf. This is in Roanoke, Virginia. Outside of anything professional, disc golf is the thing I do the most. This was actually in 2018, in the week between my PhD and medical school training, so it was probably the most relaxed I've been since, right before internship. But I quickly learned that wind definitely affects the flight of discs in Chicago, so I'll have to adapt quickly.
You do look relaxed there. Keep that attitude, please. Paul Parker, undergrad, University of Michigan, med school at Rush. Paul, looks like you're skiing. Where is this?
Hey everybody, happy to be here. I'm thrilled to have matched at UIC. As Dr. Packo could tell you, I was very excited to get to stay in Chicago and close to him and all of you great faculty here. Yeah, so this was me skiing in Lake Tahoe. I believe this was at the Heavenly Resort. I'm clearly getting probably too close to those trees, but fortunately I came out unscathed. Skiing is probably one of my favorite hobbies. I've been to Tahoe and had the fortune to go to Colorado and stuff. And hopefully when things open back up, I can get to Park City and some of those places. But if anyone ever wants to go be ski bums for a bit, I'm always down.
So you need to talk to Dr. Sedabut about his winter oculoplastic ski meeting. You should join us.
Oh, I will be there.
And Stephanie Thermosier, undergrad at St. Joseph's College, med school at the University of Pittsburgh. Stephanie, looks like a
Hi, everyone. Yeah, no, yeah. Can everyone hear me?
Yeah.
Yeah, so I'll just echo what everyone else has been saying. I'm really excited to be here and, you know, prepared to learn under such great clinicians and researchers. But yeah, something about me is that I love to cook. I like treat myself every like month or so to a new culinary item. This was a barbecue I had, I want to say like a couple August ago, and that I was gifted a salt block. So I was trying out that, but you know, I think last month I bought myself a torch, and I just bought myself a grill for 4th of July. So, you know, always amassing new culinary things. I'm not very outdoorsy, but I'm really glad to hear that a lot of my classmates are, because it's something I'm looking to get into. So I'm going to be tagging along in a lot of trips, hopefully.
Great, thank you. We'll take you up on your cooking skills soon. So that's our classes of 2023 and 2024. That's all that we have for you today. Thank you again for joining us. Let me just show you that, or give you that code again, 8390. And if your link is not working, we're going to send it out again this evening. Thank you, everyone. Have a good night.
Thank you, Peter.
Good night. Thanks, everyone. Good night.
Thanks, everyone. Good night.
Good night.
Thank you, Paul.
Well, thanks, Paul. Yes.
Jenny.